if you take someone who lives, let's say, an hour away from a major city and there's a hospital nearby, is it better for them to get care at that hospital or to come into the city to get care? And it probably depends on what they're getting care for. If it's a life-threatening emergency that has to be handled within an hour, then it has to be the place that's next to you. But there's other conditions for which it might actually make sense to spend that time to go to the city, to the larger center to get care. People look at what happens when hospitals in these more rural areas close and what happens to health outcomes. And in some cases, the health outcomes get worse for people who live in those rural areas. But in other cases, like let's say maternal care, if you're about to have a baby, sometimes the care actually gets better because you.
Welcome to the show.
Thank you for having me.
So you've got two undergraduate degrees in economics and biology from MIT. You then got a PhD from the University of Chicago in economics, and then you followed that up with a medical degree. So I would love to know, do you have the data on how many people in the world hold an MD and a PhD in economics?
First of all, I'm a glutton for punishment. It's not a lot, Joe. I'd say probably 20 or so or less have, well, probably less than that have a PhD in what we call formal economics. There's a lot of degrees that are very similar. For example, you could study health policy or um, um, yeah, a PhD in business economics, which is pretty close, actually. But if you just said a PhD in economics and an MD, maybe 10 to 15 at most. Yeah, not a lot.
And it's interesting because I think most people, when they have an interest in biology or the life sciences, they don't typically tend to associate that with economics. What was there, for you that kind of led to an interest in those seemingly not complementary fields from afar?
Yeah, it was actually total luck. I wanted to do an MD because my mom was a doctor, and so I had this interest in medicine for a lot of different reasons. And I also wanted to do research because my dad was a researcher, and I didn't know what I wanted to do the research in, but I thought maybe something like cancer biology would make a lot of sense for the reasons you just described. And so when I was interviewing after I finished college, I was interviewing for these MD, PhD programs across the country and focusing on a PhD in some aspect of biology. And when I went to the University of Chicago, uh, the director of that combined MD PhD program looked at my resume and said, "Oh, I saw you majored in economics. Would you want to do your PhD in economics instead?" And I hadn't thought about it until that point, literally. And he made this off the hand comment, which was the first point of randomness. And then the second thing is he said, "Well, let me call over to the economics department and see if there's people there today, this afternoon, who would be willing to meet with you." So he made some calls and people picked up. And I went over there that afternoon and met with some folks. And then I applied a week later. And then like 5 months later, I was there taking anatomy and then economics courses. So it was totally random. And I always knew that if I didn't like economics or if I couldn't do it, then I would always be able to fall back into something like cancer biology or immunology or something like that. But it all worked out.
Yeah, a nice little fallback plan.
Yeah,
So
exactly. I wouldn't maybe fallback plan it. Maybe there's difference between a 1,000 count sheets and 800 count sheets, maybe.
so for some more context about you, you are the Joseph P. Newhouse Professor of Healthcare Policy at Harvard Med. You're also the host of the Freakonomics MD podcast, an absolute fantastic podcast. Your latest book is called Random Acts of Medicine, The Hidden Forces That Sway Doctors, Impact Patients, and Shape Our Health. So I would love to kind of ask, because randomness, chance, these are some of my favorite topics to discuss. And it's incredible for me to even just think about things like chance. If I hadn't been at this place at this time, or because I got to meet this person, or because I wasn't here at this time, how different my life is or could have been because of it. So what was it that perhaps got you interested in the concept of randomness?
Well, so I came to this concept mostly from a sort of research perspective in the sense that I was interested in studying the effects of different interventions or policies on our health. And one way to do that credibly is to find areas where people are essentially randomized to one intervention versus another. So, for example, if you want to figure out whether one medication works to treat an illness, the way that we do that in medicine is we conduct these large randomized trials where half of the people receive the medication and another half randomly receive, let's say, a sugar pill, a placebo. And then you study the effects of that drug, and you can do so in a cause and effect way because the two groups are otherwise similar, except for the fact that one group is exposed to this treatment and the other group is not. So it allows you to establish causality. Now, there's so many questions that we might be interested in that we can't do those randomized trials. They're hard to do or they're costly. And so we search for randomness in the environment, what we call natural experiments. So that's how I came to it. But the book is about natural experiments in a lot of ways. But I think it's also more than that. It touches on what you just said, which is another way to think about this is that there's all these things that happen to us that are random, that are these chance occurrences that set our lives down different paths. And that can be a little bit scary if you think about it, right? That, oh wow, okay, I got this job, or I had this illness, or I married this person because of total luck. I happened to be standing in the line at the motor vehicle registration department, and the person behind me uh, you know, started chatting with me, and we got married. That's totally random, right? But that's not predictable, right? You couldn't build a dating strategy around going to the motor vehicle department and hoping that someone behind you will start chatting with you and you get married, right? But there are other ways in which randomness affects our lives that we can actually learn something from, and that I think is the core thesis of the book.
I think that there's a very real human need to want to feel in control. I want to feel like I'm in the driving seat with my health, with my relationships. I want to feel like there's an air of kind of predictability and agency that I have. I want to feel like if I eat well, sleep well, I take my vitamins, I meditate, that that's going to lead to me living a very, very long life. But you paint the picture very clearly in the book that there's always the possibility that randomness, that these complete arbitrary events. So I'd love to, and we will certainly dive into some of them. So I just have to talk about when you're talking about the concept of randomness in things like healthcare. What are some of the kind of some of the areas that you mean with that specifically?
Yeah. So let me talk. I'll just tell you about chapter. I think it's chapter 2 or 3, but it's an early chapter, and it describes the story of my wife who was running a race in
Mhm.
Boston, where I live, and it started in one point of Boston and went to another, and along that race route was the hospital where I work clinically. And I thought to myself, well, she wanted me to watch her on the race route. So I said, all right, I'm going to drive to the hospital where I work, park there, and watch her on the route. And as I'm trying to do that, driving to the hospital, I can't actually pull off the road to get to the hospital because the road is blocked, because they want to make sure that there's a way for the runners to run. So I drive back home, and then a few hours later, I see my wife, and then my wife says to me, well, what happened to everybody that needed to get to the hospital that day? And so I thought, that's just sort of an offhand comment that she made, but it turned into a very nice research paper. Months later, we looked at 10 different cities over 10 years, and we showed that when cities host marathons, very disruptive events for a city, 26 plus miles blocked, hard for ambulances to bisect the marathon routes to get from one side of the marathon to the other side. Very disruptive from a traffic perspective. We saw that mortality death rates for people with acute cardiac condition goes up about 15% on the day of the marathon compared to the surrounding dates. And so that's an example of how something totally random, right? If you're an older person, you're like 75 years old, you're at home, you're watching TV, you're not thinking to yourself, oh, today's a good day to have a heart attack. Of course not. And you certainly aren't thinking to yourself, huh, today's the marathon. Should I or should not have a heart attack today? It's totally random from the perspective of your heart attack, um, whether or not you're exposed to the marathon that day, and therefore exposed to delays in care, and therefore exposed to a higher mortality rate. That's random from the perspective of the person.
Someone on the podcast before said that they thought that life was more like poker than chess. Because in chess, strategically, whoever makes the most or the smartest decisions will win. But in poker, you could have a great hand and still lose.
Hmm.
So do you think that that's kind of perhaps an apt metaphor for life in some ways?
When I play, it doesn't matter what kind of hand I have in poker, I always lose. I could have the best hand. I'm staring at the best hand. I think that's a terrific analogy. I mean, so Joe, if I were to ask, I mean, I don't have any quantitative numbers on this, but like, what percentage of your life is is sort of in the poker domain versus the chess domain? I would imagine that most of it is in the chess domain. Meaning, if you do things like exercise, if you do things like study, avoid unhealthy behaviors, those things are going to tend to lead your life in one path. But even then, you could study really hard and suffer from a neurologic disease that prevents you from working. You could exercise really hard and injure yourself and be unable to work. So there's a lot of things that happen to us randomly, I think, that matter, or chance occurrences. But probably most of it is chess. But again, like you said, what is concerning to people, I think, and to me, is that there is this element of poker in your life as well, and it's hard to control that.
Yeah, I think it kind of violates some sort of expectation within me, the fact that I can work out really well, I can do all the right things, but there's still always the offhand that no matter what I do, no matter how much sleep I get, no matter what my whoop score is, I could always get hit by a bus.
Yeah,
Um,
yeah.
that really does, I think, it is an unfortunate truth of life that do you think that there's some kind of comfort in accepting it?
I think there has to be, right? Because if you live your now we're moving outside of the medical and economics domain into the life domain. But
Sure.
I think part of being at peace in life is recognizing and appreciating that there are things that are out of your control.
Mm,
We feel most distressed when there's something that's happening to us that's negative, that we feel like we cannot make positive, that we cannot control. And that's a very distressing feeling. But if you sort of give up and say, all right, well, there's some things that are actually out of my control that I can't manage, um, it gives you a sense of peace, I think. So, there's a lot of things that I can't control, and I don't try to control them, and I feel better as a result. Whether that's causal, I don't know, but um, I will say, Joe, there's when we talk about randomness, there are things that are kind of effectively random, but you know about them. So, for example, take genetics, right? So, genetically, you might be predisposed to having high cholesterol just by genetics. You could eat the best diet in the world, you could exercise all day long, and no matter what, your cholesterol level is not going to budge that much. It's still going to be high. And that's random in the sense that another person who's born, who does the exact same thing as you, might have a cholesterol that responds differently. But that is something that you know up front, and you can sort of live your life around. Maybe you take medications to control it, as we just said. But other things are really truly random in the sense that you don't even know that they're coming, and then they just
right.
happen.
Yes, yeah. Known randomness versus unknown randomness.
Yeah, yeah.
Yeah. I love that. So there's so many just fascinating questions that you pose in the book that I'd love to pick up on. Why would winning a silver medal at the Olympics potentially lead to me living 4 years less?
It's a good question. Well, I think it could be two things. One is, and I forget, there's a quote from the comedian Jerry Seinfeld in the book that, that talks about this. But basically, it's like if you win the gold, that's great. If you win the bronze, okay, you're pretty far away. But if you get the silver medal, you're like the first place loser, something like that. But I think it could be two things. One is that the act of getting a silver medal, it's like we talked about, you're so close to getting something that you really really worked hard for, and you don't get it. And that's a deviation from what you expected, and for what a deviation from what might have been attainable. And that feeling of almost attaining something but not attaining it, having it taken from you, can be a distressing feeling. And if that compounds itself over the course of a life, um, that might matter for your health. And in fact, if you look at gold medalists versus silver medalists live shorter lives than gold medalists. The other is more of a, what's the function of getting a gold medal? So if you get a gold medal, that opens up different avenues for life. than if you got a silver medal, even though we're talking about highly elite athletes. Someone who just has a few seconds or maybe even half a second better time in some sport is able to then get different jobs, different speaking engagements, access to different opportunities. All those things may lead to some fulfillment in life, maybe access to wealth or health resources that prolong their longevity. But either one of those things could be going on. Of course, I'm not thinking about a gold medalist or silver medalist myself, so it doesn't really apply to me. But
Yeah, so avoid coming second is
yeah,
the first actionable tip. So
yeah.
what kind of data did you guys, I wonder if you could talk about that, what you had to kind of look at that question.
So that study was actually not something that we did, but we talk about it in this chapter about how sort of stress and expectations can affect your longevity. And the study that we did do, which is very closely related to that, is actually looking at the longevity of world leaders. So if
Mm.
you look in our country, for example, President Bill Clinton, many years ago now, well, not that many years, and President Obama, if you look at photos of them during their presidency, both of them grayed considerably. I mean, their hair just became gray, 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 very fast. And you might look at that and say, wow, I wonder if being in office, being the president of the United States, was so stressful that it led these individuals to gray faster than they otherwise would have had they not been in office. And that then leads to the question, well, does being president lead to accelerated aging in some way? Or being prime minister or chancellor. Now, it's a hard question to study because if you look at presidents and you compare them to the general population, guess what? Presidents live longer lives. No
Mm.
surprise, right? They come from different backgrounds. They have access to healthcare resources, wealth, education, just totally different. So it's not a fair comparison to compare a president to the general population. But what if you had sort of a natural experiment? You took two groups of people that were pretty similar. One was exposed to being president and one was not. And that's the idea. So we basically looked at leaders of countries and we compared them to runners up in the elections. So we compare vice presidents and we compare presidents to people who ran in the presidential race but lost. And in our country, it's like 50-50, right? I mean, it's like 51-49. It's basically a coin flip who wins. So it is really effectively random in a lot of ways. And what you see is that world leaders live about 2.5 fewer years of life uh, than the runners up. So it says something about the impact of stress, perhaps, and the presidency, lifestyle, all that stuff on longevity.
So that is perhaps one area where one may want to finish second.
Yeah, exactly. That's exactly right. Yeah, exactly. So we tell we say that to all the presidential. You'll live a longer life. Don't
Yeah,
worry.
you live long enough. The silver lining.
Yeah.
I'd be interested to know just one thing that was popping into my mind. I'd be interested to know how doing an MD PhD program may age one, the
Yeah,
longevity.
that's a good question. Well, my eyebrows are getting gray. You can't see it on the you. If you zoom in on the YouTube, you'll see. But to be
Yeah.
honest, I actually enjoyed my time. Most of my friends who finished college, they went on to have real jobs and real responsibilities. I was in school for a long time, and that's good for a lot of reasons and bad for a lot of reasons. But the one good thing was that I didn't feel this sense of I didn't feel the weight of the world for a long time. I was just in school learning, and it was very structured what I had to do, and it's a lot of I think um, ease in that, for lack of better words. It was hard, but it was easy in some ways.
There's a chapter in the book where you talk about kids with summer birthdays being more likely to get the flu. So I wonder perhaps if you could talk about this whole phenomenon, these kind of age effects that you found.
Yes, absolutely. Yeah. So this is a story. A lot of my research comes from things I see either in my life as a parent or just someone who's living life, or something I see in the hospital as someone who takes care of patients. And this one comes from my personal life. We have a couple kids, and a few years ago, I was taking my son to the pediatrician. And here we have annual checkups that are timed around a child's birthday. So when he turned 3, I took him to the pediatrician right around his 3rd birthday, and he's born in August. And as I'm leaving the pediatrician's office in August a few years ago, the nurse says to me, "Come back in a few weeks, we'll have the flu vaccine ready." And so I thought, because the flu vaccine is typically available in offices basically the beginning of September or very late August here. And so I thought to myself, wow, had my son just been born 3 weeks later, his annual checkup would have been in early September, and we would have gotten the flu shot in the office that day, right? But instead, I had to spend hours to figure out how to get him back to the office to get a flu shot. And it literally took me hours to figure it out. Imagine if you live 45 minutes away from your doctor, you've got to take time off from work, half a day easily to come in, get them vaccinated, and then go back home.
Mm.
And so what we did is we looked at this. We looked at data from a large insurance database where we know who's getting medical care, when they're getting medical care, how old they are, what diagnoses are they receiving. And what we showed is that kids with summer birthdays, three things are true. The first thing is that they are less likely to get the flu shot, quite a bit less likely than, say, a kid with an October birthday. And the reason why is when they go for their annual checkup, the vaccine is not available in the office, so they have to come back. That's an extra step that they have to do to get vaccinated against the flu. Second thing is, well, if they don't get the vaccine or if they're less likely to get the vaccine, are they more likely to get the flu? And the answer is yes. Those kids, young kids, are more likely to get the flu. And then the third thing is because flu is infectious, their family members are also then more likely to get the flu because that index child did not get the vaccination because of their birthday. And so they got the flu, and then a family member got the flu. And these effects that we find are really quite dramatic. I mean, they're not small at all.
Yes, yeah. And I was kind of thinking about that from perhaps a second or kind of third order effect, because the effect of young Timmy getting infected with the flu is probably little risk. But if he then spreads that to grandma that gets sick and clogs up a bed in a hospital,
Yeah.
that takes time. It's emotionally draining for the family, for the hospital. So that to me seems like a clear indication of not an upfront cost, but perhaps a secondary cost. Is that kind of how you view that?
Yeah, that's exactly it. And I'll say two things. One is, well, let me tell you a story, and then I'll tell you some economics around it. So when we first moved to this town that we live in Boston, it's right outside of Boston. It's called Wellesley. I was going to the local bank just to set up banking, and I was talking to the bank clerk, and the bank clerk, asked me what I did. And I said, well, I do mostly research, but I also see patients at Massachusetts General Hospital. And then he said, "Oh, well, my dad, or I think it's his dad was just hospitalized. He was like 90 years old." I was like, "Oh, what happened?" He said, "Well, this is the bank clerk told me. He says one of my friends brought his 2-year old over for a play date, and the 2-year old had a fever and a runny nose, and the friend brought the child over anyway, and then the bank teller's son got sick, and it all turns out this was all the flu. And then
Mm.
the granddad of that little boy, who's this bank teller's father, he lives in the house, also got sick. And he got so sick that he had developed a very bad respiratory influenza pneumonia. He actually had a cardiac arrest, which is when your heart stops. That's an incredibly high mortality condition, and you take that in a 90-year-old, it's almost certain that they won't make it. But remarkably, he made it. So he was telling me the story about his granddad who was in the ICU, made it, and this was a front and center example of how a child can make an older person in the house sick. And you use the word second order, third order, sort of these additional effects. In economics, we call these sort of spillover effects. There's the primary effect, which is the child getting sick, and then there's a spillover effect of a loved one, a family member, and it can be the same, also getting sick.
I was thinking about, from a kind of a policy perspective, and I was thinking about it kind of from perhaps a behavioral perspective. And I think that particularly here in the UK, I think many people kind of speak about the drudgery that they have to go through to get to perhaps get healthcare. And there are many, many reasons for this that you could spend a long, long time speaking about, but just for kind of a thing, people they'll be perhaps waiting, weeks to get an appointment with a physician or a dental appointment, or waiting hours in A&E. And I appreciate, of course, that there are obviously upfront costs with these. But I just wonder perhaps if healthcare did perhaps consider or did perhaps start to become more cognizant of these, as you said, these spillover effects. Do you think that in the long run that could have a net positive effect on perhaps both the hospital and the patient care?
Yeah, I think that's partly true, but I think a lot of it comes from how we think about healthcare, how we finance it, how we pay for it. Um, one thing that is striking about healthcare, both in the UK and also in the US, is that healthcare is probably the thing that we care most about, but for which the service that we receive is perhaps the worst relative to what we value, right? I mean, I can order something at 11, and I have ordered things at 11 p.m. at night, only to have them show up at our house by Amazon between 7 and 9 a.m. the next morning. I mean, that's like amazing that you could do that. You can go make an appointment to get your eyebrows plucked within the day. But if you've got something serious going on medically and you call your PCP's office, maybe you can get in that week, could be
Yeah.
even longer, right? And there's a huge, you know, divergence between how much we value something and the access that we have to it. And a lot of that, I think, stems from how we sort of pay for healthcare and how we prioritize resources. But that, to me, is a fundamental problem. We talk about the cost of care. That's obviously important, but what we're talking about now is access to care, right? That's a huge issue. Like if I can't see my doctor or a specialist for months, that's not very useful, I think, for most people.
If I were to live in a city versus if I were to live, out on a farm in the middle of nowhere, or, right out in the suburbs, how would that kind of affect my lifespan, my perhaps chances of making it through if I had, I'm not sure, a cardiac arrest, or if I had something very bad that happened to me? How would that kind of factor into that?
First of all, Joe, let me just say, if your podcast does well, you have a home in the city and you have a home in the farm. So my prayer for you is that you have both one day.
Mine
Um,
too.
it's a great question, and there's two things that I think, or at least two things that would matter. So first is, what is the lifestyle in the city? What's the causal effect of the lifestyle in the city versus the lifestyle outside of the city? And there's so many things that go into that. One is just sort of, what are the types of foods that you have access to more easily? What's the level of exercise that you might get in those two different environments? Air quality is a big thing now. What's the air quality in the city versus 50 or 100 miles outside of the city? Could be quite significant in terms of the difference. So those are things that are just sort of risk factors for the type of health that you will have. But then there's another thing which I think you're touching on, which is, all right, well, if you're at your home in the city and you have chest pain, what type of medical care and how quickly will you expect to get it versus you have that same problem an hour away? And the marathon story and a lot of other medicine tells us that that time matters quite a bit. So the delay in care could be quite significant if you live further away. And we see that all the time. Like if you live next to the hospital, you're going to get much quicker access to care than if you live in one of the islands off the coast of Massachusetts. We have to fly those people over here. It's time consuming. Um, but there's a second thing which is kind of interesting, and we don't talk about this in the book actually, but it relates to the quality of the medical care that you have access to locally. So if you take someone who lives, let's say, an hour away from a major city and there's a hospital nearby, is it better for them to get care at that hospital or to come into the city to get care? And it probably depends on what they're getting care for. If it's a life threatening emergency that has to be handled within an hour, then it has to be the place that's next to you, whether it's good or not. It has to be that place. You cannot wait to go to the city. But there's other conditions for which it might actually make sense to spend that time to go to the city, to the larger center to get care. And there's nice examples of studies in which people look at what happens when hospitals in these more rural areas close and what happens to health outcomes. And in some cases, the health outcomes get worse for people who live in those rural areas because they don't get access to life-threatening care for life-threatening conditions. But in other cases, like let's say maternal care, if you're about to have a baby, sometimes the care actually gets better because you have to now spend an hour to get somewhere, but you're getting more specialized care by doctors who do a lot of what you need help in. So it kind of depends. But
Ah,
where you live might matter quite a bit for all those reasons.
that's super interesting. And aside from pregnancy, are there any other kind of health related issues that could be beneficial to travel perhaps a little bit further?
I think anywhere where there's a high degree of specialization that leads to better outcomes, and for which the time is not so much of an issue, I think would fall into that category. So if we're talking about cancer care, or let's say some advanced neurologic care, so you have someone who's got a neurologic disease that is uncommon, those kinds of things you want to be seen by a physician who spends a lot of time seeing those types of people, who's aware of what it goes into the diagnosis, aware of prognosis, aware of what the newest treatments are. It might even be something like access to a clinical trial. So there are certain medical centers in the US where clinical trials for new medicines, new cancer medicines, are often performed. And if you happen to live near one of those centers, and you happen to develop a cancer which is being evaluated in a clinical trial in that center, you might have a better outcome because you get access to a clinical trial that would otherwise be difficult to be a part of.
I love this. I have to say, I love this. I think that's such a trenchant point. And I would just have to kind of go back and perhaps pick up on age effects, because one of the things that I was uh, just so curious about was in the book, the points that you make in terms of age and ADHD, specifically when a person's birthday is an ADHD. I wonder, could you perhaps talk about what you learned there?
Yeah, sure, absolutely. So this is another one of these birthday sort of stories, which
Mm.
is if you look at kids, so many, almost every country, and certainly all the states within our country, have these cutoffs for entering into school. I'm not sure what it is in the UK, but I think that there is a cutoff. But
Yeah.
in my state, if you are age 5 by September 1 of a given year, then you can enter kindergarten. If you turn 5, let's say on September 5th, then you have to wait a year. And so there is a cutoff for entering into kindergarten based on your age on a specific date. And what that does is it means that in any kindergarten class in our state of Massachusetts, the August born children are going to be the youngest kids in the class, and the September born kids are typically going to be the oldest kids in the class. And the reason that's interesting and matters for ADHD is that when an August born child is inattentive in class, maybe a little bit more active than the teacher would like them to be, that might then, you know, risk the diagnosis of ADHD being handed down to that child, when in fact it's just that the child is almost a year less mature than, you know, his or her peers, the September born kids. And so here's a situation where a disease is being diagnosed based on a subjective assessment. This is how a child's behavior compares relative to their peers, but it's driven by something totally random, which is your birth month. And by the way, you wouldn't see this for diabetes, right? There's an actual lab test that you can perform to
Mm.
see whether someone has diabetes or not. Those types of diseases are not susceptible to this problem. It's the ones where the diagnosis is really more subjective.
Right. And I would imagine that particularly, in younger adolescents, that being 11 months younger than your peers, that is a pretty substantial difference. That's not true after 25 or 26. And I suppose the problem also that comes with an ADHD diagnosis is perhaps if uh pharmacology comes involved, someone starts taking medication for it. Do you Are there kind of any estimates on perhaps what the type 1 error is of false diagnosis for people born in August with ADHD?
Yeah, great question. So the core question is, all right, we see that kids who are born in August are more likely to be diagnosed with ADHD. Now, we don't know if that's an overdiagnosis or an underdiagnosis, right? So this type 1, type 2 error terminology that you just used. Some of these kids could be overdiagnosed because they would have matured and developed and grown out of their symptoms. So we would call that an overdiagnosis. But some of these kids might be appropriately diagnosed and then appropriately treated with medications or other therapy. The only way to know for sure is to say, all right, let's look at the scholastic performance of these children, or conduct detailed behavioral tests to see how they're doing. We weren't able to do that in the studies that we performed on this question. My sense, looking at the broader literature, is that there's more of a concern about overdiagnosis, but I think we always have to have a little bit of caution, because anytime we talk about a disease being overdiagnosed, okay, people are quote unquote overdiagnosing this condition. There's also the risk of underdiagnosis.
Mm.
And the same is true for reverse. If we underdiagnose a bunch of diseases, we also are probably overdiagnosing them in some places. And that is unfortunately part of the art of medicine. We haven't figured out how to get it right so that the diagnosis is specific to that person and it's accurate for that person. And if you don't have it, you don't have it. And if you do have it, you do have it.
Right. And I suppose, no doubt that randomness plays a part in some way in terms of that process. I would love
Yeah.
to ask, from a kind of a policy perspective, is there kind of, just hypothesizing here, anything that could be done about that potential vast difference in age, in terms of, these kids that, going into kindergarten or whatever, there's such a difference in, the age of them at that kind of developmental period. Is there anything that could be done, or do we just wave the white flag and let it be done?
Yeah, I mean, there's probably a lot that could be done, some of which I have thoughts on, and a lot of which there's probably others who are focused on, education of young children that would know a lot more about. But just on the medical side, I think two things are important to keep in mind. One is that awareness matters, right? So if you're a parent and your child is um, someone is considering a diagnosis of ADHD, I think it is relevant to present the information about when that child is born. If that child is an August birthday, they're younger for their peers. And so at least it should give the clinician a moment of pause. They may not change their diagnosis, but if they're not considering that important piece of information, then they're missing out on something. They're missing out on an important fact about this child that should be considered before you make that diagnosis. So awareness is actually quite important, I think, here, information. And then that's true not just for parents, but also for doctors. And then there's also more operational things that you could do. For example, now we have these electronic medical records, which doctors use and patients can access. So anytime a doctor is going to make a diagnosis, they're clicking that button that says ADHD. The computer system could say, are you aware that this child has an August birthday? And that study suggests this. And that's a way to sort of insert into the clinical decision making just for a moment, to give pause to say, all right, we've used the electronic medical record to know that A, this child is born in August, which the computer would know. B, this diagnosis is being handed down. And C, giving you, the clinician, a moment to say, all right, is this appropriate or not? Or maybe actually I just wait 6 months to see how the child does. That would be a very reasonable thing to do clinically.
I think that another, uh, perhaps, point that has been taken that I've taken away from this is there seems to be, some pretty substantial benefits for a child to be born in September. So if if you young parents out there, perhaps consider mating in January
Yeah,
or
exactly. Yeah.
September.
Yeah.
um, I would love to kind of ask you some other things, because we kind of talked a little bit about, type 1 errors about and type 2 errors, false positives, uh, being diagnosed with something when you don't have someone, or not being diagnosed with something when you do have it. And the reason why I'm interested in this is because I think, particularly in recent years, there's been, particularly in the kind of self-improvement space, there's been this flux of people that have rushed to get blood work done. They've rushed to have all these kind of complex scans done on them. I know people that do this. And in theory, I mean, to kind of get an idea about what's going on inside, I think that it kind of makes sense. But I suppose when you run the idea and you come back with all these various different biomarkers and scans, um, one would imagine that statistically speaking, at some point, someone is bound to either find a type 1 or a type 2 problem there. Do you have perhaps any concern about people doing that kind of testing?
Yeah, I mean, I think there's concerns for a couple of reasons, but ultimately, Joe, at the end of the day, what we need is evidence, right? So if, for example, there's a new technology that can cheaply, efficiently, uh, scan the body, combine it with other laboratory information, and make predictions about health. What we want to know is A, are those predictions valid? B, if we present that information to people, does their life become better in some way? And I use that term in a general way. Become better in the sense that it allows them to then get treated or to modify their life in a way that prolongs the length of their life, for sure, right? If you identify a cancer that you otherwise would not have identified till later, that would be valuable. But B, also to balance the the sort of risk of being concerned about things that were never going to be a problem. And my guess is that the people who run to get these sorts of tests, more sort of, whole body screening, for lack of better words, they're probably more comfortable with getting sort of false positives and then just going about their lives and living their lives and not worrying to themselves, all right, this one biomarker was a little bit aberrant. Am I going to develop Alzheimer's in 20 years? And I'm now going to be afraid of that for the next 20 years and not live my life the same as I otherwise would have. Um, well, that's one concern we always have in medicine. And my own view is that we want to be cautious about running tests, not just from the cost perspective, the healthcare system cost. That's important, but I worry less about that, and I worry more about the impact that it has on people's well-being. You
Mm.
cannot unknow something, and so if you know some piece of information, whether or not it's relevant to your long-term health or not, we don't know that, right? But once you know that fact, if you are the type of person who will dwell on that information, will see patterns that emerge in your life that all sort of say, oh, wow, I forgot my keys at home yesterday, and that biomarker was positive. Is this early indication that I have Alzheimer's, right? Like people connect patterns all the time. If you're one of those people, this is not going to be good for you. But if you're one of those people who's like, I just want to know, I'm fine knowing, I'm not going to be worried about it, then I think that's a different ball game entirely. But
Yeah.
either way, we want to know whether or not the stuff works or not. That's important.
If I have surgery on my surgeon's birthday, am I more or less likely to have a better or worse outcome?
Oh yeah, good question. You have a worse outcome. So let me say one thing that I love about this kind of work, and I've specialized in these types of questions, which are sort of quirky. They use large data, and you don't have to be in medicine uh, to understand the concept. Like they're clear once you think about it. But because I work and I specialize in these types of questions, I'm able to work with people who have ideas here. And so this was an idea that a colleague of mine, actually a former student named Yusuke Sugawa, who's a researcher at UCLA in Los Angeles, he came to me with this idea, and I was like, huh, Yusuke, I don't think we're going to see anything here, but it's not hard to look. And if we do see something, there would be plenty of things that we could do to make sure that it was actually a true effect. And so what we did was we basically looked at surgeons. We knew when their birthday was. We had information on that. We linked that to the surgeries that they were performing. And what you see is that on the day of a surgeon's birthday, the mortality rate of the patients that they perform surgery on is higher than on any of the other surrounding days in the plus or minus, let's say, 2 weeks. And we think that's a function of distraction, right? Like think about what happens. Surgery is complicated. You have to be very focused. Small distractions might matter. And so if you're in the operating room operating and you're thinking, all right, well, what are my plans for this evening? Or the scrub techs and the nurses and the trainees are talking to me about my birthday, or my pager's going off, or my cell phone is going off with that little iPhone, fireworks if someone says happy birthday. All those things could be distracting, and even minimal distractions could have an effect on outcomes. But it's always hard to say because you never randomize people to say, okay, I'm going to distract this group of surgeons and not distract this group and see what happens. You can never do that, and you wouldn't want to do that. But here, we think this is sort of happening naturally. It's on your birthday. There are naturally going to be more distractions on that day, and we see this increase in mortality.
That I find so fascinating. So if someone's listening to this and they see a surgeon with a happy birthday badge on, perhaps
Yeah, say, slow down.
yeah.
Turn your phone off. Turn your phone
Turn your
off. Yeah.
phone off. Man, I love this. There's so many fantastic examples from the book. I would just kind of just have to perhaps pick up on two general questions and perhaps start to wind down. If there are healthcare professionals listening now, um, are there any lessons that you think that they could take away from the book in perhaps terms of how to improve care, or from their own perspective? Is there anything that you could take away from this?
Yeah, I think there's a lot of things that are sort of actionable items for the practitioner in terms of how to think through diagnoses, how to be aware of certain cognitive pitfalls that clinicians may suffer from when they're making a diagnosis decision or a treatment decision. So there's a lot of that kind of stuff that's embedded in the book. That's not the purpose of the book, but a reader would be able to grasp that information and use it, I think. But to be honest, what I really would want anybody who's involved in healthcare to take from it is an appreciation of how what they see, what they do in their life could be just a planting bed for really interesting ideas. When I work with clinicians or trainees and talk with them, the lives that they lead are very complicated. They do so many interesting things. They meet and interact with people at in all different walks of life, in different points in their life. The stakes are very high. Lots of information has to be processed. These are all areas where there's fascinating questions that could emerge. And most clinicians are probably just kind of going about their day treating patients. And the point of this book, one point is that, look, if you're in the business of ideas, there's a lot of ideas out there. You just probably haven't stopped to think about what they might be. And that's really what I would hope for people who are in healthcare to take from the book. And then for the vast majority of people who read it who are not involved in healthcare, just think about your health and the things that you experience on a daily basis and what ideas come to mind from those interactions.
Yeah, and perhaps I think one thing that has come that I've become more accepting of, certainly since I read the book, is perhaps becoming more accepting of the idea of randomness in our lives. I think your book really beautifully illustrates it. Because I think there's there's this natural tendency to just think that we're in total control. And we're not. There's always, as we kind of talked about at the start, this element of chance. Um, I got one last question from the book that I would love to finish on before I ask you to our final question and wait to sign off. Um, I just, this one just come back to me, so I can't let you go without asking this
Oh,
one.
please. Yeah,
Um,
yeah.
if I'm having end of life care,
Mm-hmm.
and I think it's well known politically that this is an area where people hold different views. I think some people, they perceive life as precious and that they should be preserved at all costs. But contrastingly, I think other people hold perhaps different views on the topic. Um, would it affect the care that I receive if my physician, my doctors, if they have one political orientation in comparison to the other?
Yeah, interesting question. And so the last chapter of the book is called Politics at the Bedside, and we intentionally actually left that for the last chapter because one thing that we've all experienced in the last few years of the pandemic is the politicization of medicine, of healthcare, and public health. And so we couldn't write a book and not touch on that at all. But we talked about some of our work, which is actually published in the British Medical Journal and the
Ah,
homegrown journal. Um, and we looked at information on doctors. We had information on their political donations in the U.S., and so we could identify liberal versus conservative doctors, Republican versus Democrat doctors, and we could match that information to the types of care that they provided people at the end of life. So these are people who were hospitalized, who were either going to die in the hospital or at high risk of dying very shortly after being hospitalized. And we look to see whether or not, if your doctor is a Republican, are they more aggressive at the end of life? Do they do or recommend treatments that would be intended to prolong life above and beyond what we might see for a Democrat doctor who might have a different view about sort of the sanctity of life or end of life care? And I think somewhat reassuringly, we do not see any difference between doctors there. And that's not to say that doctors wouldn't have different beliefs for their own care, but it certainly doesn't seem to bleed over into the care that they offer to patients, which I think is maybe reassuring, that in this area of politics and medicine, that there are certain things that don't get crossed, and I think that's a good message.
I got one final question for you that we ask at the end of all our podcasts before I ask you to sign off, tell these guys where they can connect with you, where they can get the book, etc. And the final question we ask at the end of all our podcasts is, what makes a life worth living?
Oh, hmm. The short answer would be ice cream for me.
Me too.
uh, um, yeah. Let me see if I can think of something different. I mean, I'll tell you how I spend my days. Like, we're doing this interview now. It's 8:30 in the morning. At 12 o'clock today, I'll play soccer with a bunch of people that I play with almost every day. And I'm not a great soccer player, but I almost never schedule anything during lunchtime for that purpose. It's because, obviously our life is determined by the connections that we have with other people, and that brings almost everybody a lot of um, benefit. But I think, I don't know, I think it's the connections that we have with people and finding something that we enjoy doing almost every day. There are some days I remember in training where we'd work 80 hours or more a week, and it's hard to look at the start of the day and think to yourself, wow, this is going to be a good day. It's going to be a disaster because you're going to be in the hospital for 24 to 30 hours. But even then, on those days, I would always find something that I enjoy doing, whether it be making a makeshift ice cream with some chocolate ice cream, graham crackers, and some peanut butter, and mixing it together and pretending that it's a Haagen-Dazs or Ben and Jerry's, or cracking jokes with other colleagues of mine who are also in the hospital overnight. Those little things mean a lot, and it gives you something to look forward to, or gives me something to look forward to every day.
Where can these guys connect with you? Where can they get the book? Where else would you like our audience to check out?
Okay, well, so the book is called Random Acts of Medicine. You can go to Amazon, go to your bookstore, and buy it there. And we also have a Substack, which we just started, called Random Acts of Medicine. It's with Chris Worsham, who's a critical care doctor at Mass General and Harvard, who's a colleague and friend of mine. And so it's a way for people who read the book to get connected with these ideas, to get connected with us. And there's a lot of stuff that we didn't put into the book that we talk about in our newsletter. And yeah, that's the best way.
Everything discussed today, including a link to get the book, will be linked below. Man, this was such a pleasure. As I said, I love the questions that you guys are asking. It was a book that I really found difficult to kind of put down. So man, I really, really enjoyed reading it. And yeah, Bap, thank you so much for taking the time to come on, man.
Thank you. You're the man. I appreciate it.